Yes, thank you so much and welcome to the show. I'm so delighted to see you. And we
Thank
feel
you
so
so
honored.
much for
And I
having
know
me.
Doreen is just so excited that you are here. Guys, today we are so
Yes.
honored to have, I'm not going to introduce her, she's going to introduce herself. I love the Lord. I am a breast cancer thriver. I had breast cancer in 2020. And I know that from speaking out, I get to encourage more people that are going through cancer. And I know from a doctor who told me before and told me, hey, you know what? Looking at my patients, you really encourage me because many of the patients I deal with have lost hope and all that. And I normally direct them to your life. So that really made me feel nice. So to having a medical practitioner coming in, but I'm going to allow our guest to introduce herself and tell us more about her and what she does. And I know you'll be excited to know who she is. Go ahead.
Thank you so much for giving me the opportunity to be here. I believe it's a privilege, it's an honor, and I'm just blessed to be in this space and get to connect with everyone in this forum. My name is Dr. Cheryl Agutu, born again Christian. A medical officer at Texas Cancer Center. It's been an interesting experience working in this space, getting to engage with many patients. It's been such a blessing. I feel like God is ever intentional about where He positions us. So it's been a period of growth for me as well. I'm also the founder of an organization called Net Plus Kenya that supports children with disabilities and young girls with menstrual health issues in Kawangware. Yeah, I think that's it for interest for now.
I did not know about the mental health part and the menstrual health. I did not know about that. I know
Yeah,
we are going to know more about what you do. Maybe one time you just come mainly for that, or when you have
yeah,
an activity, we can send you Doreen and we get you live and we get these wonderful people to also help in to come and pitch in a little in case we can make a difference with pads and things like that.
exactly.
Thank you
That's
so much for
awesome.
what
Most
you do.
definitely.
You know,
Yes.
now that in your practice for now, I think a little over a year, within
Mm-hmm.
the cancer sphere and area of cancer, what is your observation about or regarding cancer, the trends of cancer in Kenya or East Africa? Is it
Mm-hmm.
something that you see going upward positively, or more lives are being saved, more people are surviving, or is the trend going towards the lower end?
Okay. I think in the cancer space, there are a bit of positives and negatives. The shocking things are the statistics behind it. Like I was looking into that and we're seeing in 2020, there was a noted increased incidence of cancer by 47,000. So you can imagine. And there's a projection that that's going to go up by up to 60% in at least the next 2 decades. Because the thing is, our life expectancy is increasing, so we're living longer. Then there's more diagnosis. Before there were people with cancer you didn't even know about. They died suddenly. Nothing was ever really clear as to what the cause of death was. So there's that. There's also the fact that the population is also growing. So as we grow, the risk factors are still there. There are more people smoking, drinking, again, because of mental health issues. So all these things, unfortunately, imply that the number of cases of cancer are gonna be going up unless we find measures to curb that in time. I think generally there are key areas that attribute to like the negative outcome of cancer. One of them being social economic factors. I think that's something we've had again and again. The money is always a problem. If we're not able to fund our own health, then it becomes an issue. Then there's also our behavioral patterns. I think maisha inakuwa ngumu, we get stressed up. So a lot of people engage in activities that are more toxic for self, like drinking a lot and smoking, or even engaging in sexual activity, unprotected sex. So all those risk factors or behavioral patterns are making the outcomes for cancer more negative. And also things like physical factors, accessibility to healthcare facilities is also an issue. And you find even the medical services that are there, the optimum to be able to meet our needs. So I think those things in general have made the progression progression to be on an upward scale, especially in the setting of us being in a middle to low socioeconomic country.
Yeah, that really opens eyes to a lot. Now, if we look at our country and you being a practitioner in Kenya, is there something, or does it seem like the government is doing enough to curb some of those things that are causing the numbers to really go high?
Yeah, I think that's a good question. Most of the time, we normally throwing shade to the government, but I feel like there's some things to acknowledge. One of the biggest things that people always complain about when it comes to health is health financing. Now, we've always had these talks about NHIF, the social health funding thing, and one thing I've come to appreciate, it's not enough. We're not saying it's enough, but most people don't know the level of help that NHIF gives even for treatment. You can find, for example, what I've noticed is when you have NHIF, your NHIF is able to cover 20 sessions of radiotherapy. Your NHIF is able to cover 6 cycles of your chemotherapy. Your NHIF is able to cover 50 to 70% of the scans that you do. Now, that's not going to be always enough, but for someone who has zero, then it's something that can make a difference. Considering what you're contributing is 300 bob per month, and or those guys who are employed, 2.5% of your salary goes towards that. So if there's ever a greater message, it's to plug into such programs, being able to ensure that our NHIF accounts are active or able to utilize them. I think a lot of people don't know that. That's one thing I've noticed. We find patients who come from different parts of the country, all over, and especially from rural areas. They don't know about NHIF. They've not been registered. So someone comes, you see they need that level of support, even if it's just a foundation. But without that, then it becomes you're stuck, because when you wait until you get sick, then you have those waiting periods. You have to wait 2 months before your card is active, etc. So I think that's one area that the government is trying to do something about. There's also been steps to be able to do awareness programs. There's breast cancer awareness programs, prostate cancer awareness programs, cervical cancer awareness programs, especially with the HPV vaccination that's been rolling out, and we're trying to increase the number of young girls who are getting the vaccination. So there is a lot that the government is doing, and also organizations like the National Cancer Institute, in terms of getting to train more medics to be able to enter into the oncology space. The number of oncologists was so few, but now because of such programs, we are seeing an increase. And the idea is to ensure that in each county there's at least an oncologist present to be able to reach people where they are. So it's work in progress, but I feel like there are steps towards making things better now that people are trying to give cancer the attention that it deserves.
Wow, yeah, the government is really trying on that end. But now, when you talk of awareness, do you think the awareness that is created within the big cities, the capital, Eldoret, Kisumu, Mombasa, is it the same as the kind of awareness created in Migori, Nyandarua, and Kakamega?
I think for sure that's definitely a gap. In the rural areas are so neglected in such a major way, because you find in the rural areas there are a lot of barriers. First of all, in terms of the tools that we're using to convey this awareness, are they easily available to people in the rural areas? Because we're looking at things like also educational level of education in terms of dissemination of this knowledge, and how easy is it for them to receive this kind of tools. Because, for example, if I'm from the rural area, and for example, I feel a lump in my breast, the facility that I go to, do they have the tools to be able to carry out the proper diagnostic to be able to come up with that diagnosis? Because you find most of the time these people come, there are 3 main things. These people who have breast lump and they go to the hospital treated for infection most of the time. By the time they're coming to the hospital, it's a really large ulcerated mass. And then two, you find cases for guys who have gastric cancer. They've been treated for H. pylori severally, because most of the time in the facilities, that's what they can test. So you find that the diagnosis of cancer, the screening itself and the diagnosis becomes a gap, because even the tools required to make the actual diagnosis are not available. And then we also have cultural factors in the rural areas. Most people tend to also rely on herbal medication. I've had patients say that I was told I can apply this and it'll be okay. Or like there's this thing I had once where there's a patient who was told that you squeeze the cancer out. So they literally cut where the mass was and they did some sort of things. So by the time she was coming to the hospital, it really didn't look good. So we have cultural barriers, we have barriers in terms of diagnosis, and even the healthcare workers, for example. Unfortunately, even us, for our level, the it coming to a head might not be that common. So you can find someone has a lesion, maybe it's a melanoma. Me in my head, as the person seeing the patient, I'd be thinking maybe this is a complication of diabetes or hypertension, because you're thinking more of what happens more commonly to you. So I think that's also another challenge. And definitely the beauty of being in such platforms is for us to come together and say, how can we best reach the people in the rural areas? Because it's more than just like putting it on TV. How many of them are actually watching TV? And there have been good programs like radio. People are trying on radio. I've had my colleagues go on radio and they've had to do these awareness sessions in the mother tongue, so that even people who don't understand English or Kiswahili can be able to pick that up. But what are we doing to demystify cultural perspectives when it comes to cancer? How do we eradicate people who for many years have believed that such things are because of witchcraft, because of someone looking at them badly, one or the other? So I think there's still a big gap that we need to fill in that front.
Wonderful. Now that explains a lot. Now when we come back to, again, still in the practice and what you observe in the practice, where is counseling placed? In, for instance, maybe the private sector that you've maybe worked for some time. Have you seen counseling coming in diagnosis? Saying those 3 words, you have cancer. Is there some kind of therapy surrounding that time that this pronunciation is made? And at the time when a patient is maybe told, right now treatment is not working, there's nothing else we can do. How does counseling come in? Do you see counseling happening, or things are just said, or things are hidden or covered for patients until they succumb? How is it done, like you've observed it?
All right. So I think there are 2 angles I've seen. So first, I've seen patients who've come when they already are aware. That's majority of the patients. But unfortunately, most of them, when you ask them, because the first time I personally engage with a patient, my idea is to hear from them. Okay, you've brought for me these reports, and what is your understanding of what these reports is? Because you find most of them, they say, nilipatiwa hizi makaratasi nikaambiwa niko na cancer, naweza kuja hapa. So translation, they can come here for treatment and they have cancer. You find there's not much of counseling that's done. Or that those patients who are given the biopsy report and they're on Google trying to figure out what this is. So they've already found out the diagnosis by themselves. They're scared. They don't know what to do. And unfortunately, people have the mindset that cancer is equivalent to death. So by the time they're coming, they're scared. They can sense this fear of the people who've brought them, their spouses, their caregivers who are already looking at them like, this is a gone case. I've also had patients whose relatives have told me they don't know about this, don't tell them. But you can't treat someone who doesn't know what they're having. Because how do I give you treatment that's going to have strong side effects without you knowing exactly what you're having? So we personally, from where I work, we incorporate that counseling as we do, as we make the plan for the treatment, just to understand at the end of the day, whether it's stage 1 or stage 4, the thing is, we will attempt treatment for all patients as long as the performance status is good. And it's a journey. That's the other thing that we try to make it clear. Most people think like, I'll get treatment like this and that's the end. But we're also trying to emphasize from the beginning, it's a journey. I'm working with you. Even after you finish this round of treatment, I need you to continue coming to see me on a regular basis, because we need to screen for recurrence. We need to make sure you're doing okay. And I think unpacking all that just in a broken down manner in the beginning makes a big difference, because even as they start that journey and not by themselves, then they have a big picture of what to expect. And just, I've seen people really broken when they hear the cancer has spread one place to another. Maybe it's in the lungs or the brain. And for them, that's crazy, because someone is thinking, if these cells are in my brain, that's it, I'm gone. Or if it's in my lungs or in my liver, that's it. But just trying to break down whether it's stage 1 to stage 4, in as much as the prognosis is different, there is still hope. I am in no position to tell you that you will not make it to 1 year or 2 years, because I personally am a believer in the number of days God has written for you. So that's cast in stone. And mental health is really important, because at the end of the day, if I'm just telling you have cancer and this is the treatment, that's it, your mental health plays a big role, because we've had patients who have walked away, like in other settings, because they were scared. Especially for breast cancer, the thought of surgery for many patients has been very intimidating, because someone would think, I'll go for surgery, I'll make it out of this, or I'll go for surgery, how will I look after this, how will it affect my relationship with my husband, etc. So I think, as you've said, it's really important to just have moments of counseling progressively in the course of treatment, just with an understanding of what the big picture is in terms of even the follow-up plan thereafter.
Wow, that's great. Now, I'm just going to piggyback on something that you mentioned, and you said you're not in a place to tell a patient that they have this number of years. Now, we now get to the question of prognosis, because I remember being told what my prognosis was, and I was crying. I was telling my brothers, oh, so I will not get to 80 years. Oh, so I will not. Then my brother said, even those 80, 90 people, they are abandoned. Why do you want to get there? What's the problem with you? Even 60, 50, 40 is just fine, But here they tell you, this is the prognosis. This is the likelihood that this is how many years you live and all that. You don't get to tell people that.
So we have cancers that are aggressive. We normally do what we call family therapy. And also like individualized, where I get to tell you that this is a prognosis. That's facts. There's no way to deny that. Like, this cancer has gone here and there because of this and that. Then the prognosis is poor, or like we expect complications. Sometimes also because of the status of the patient in terms of being very sick. You find patients who have other comorbidities in addition to the cancer. You have patients who have HIV, diabetes, hypertension, and still have the cancer. That's a bit much for the body, especially with other complications as well. So it's very important to actually not sugarcoat that in terms of not being honest, that, okay, this is how it is. We have brain tumors that are quite aggressive, and you can actually see such a rapid deterioration in a short period of time. It's normally good to make that open, especially in the setting of family who understand and who will support. It's not me telling you that you're going to die on the 10th of April, but it's me telling you that because of this and these things, then it's going to be a bit heavy for your body to handle this and that. And this is what we can try do, but the rest is beyond our control. So I feel like there's a message behind that. We are sharing the prognosis, but we are also sharing what we can do and what we can't do. And we've seen people who we thought were gonna go very soon, and they've proven otherwise, which is testimony after testimony. So there's always one or the other exceptions in everything.